Welcome everyone to the video on monoclonal antibodies. What is the first monoclonal antibody that we see? The first one is about TNF alpha inhibitors. What is the aim of TNF alpha? TNF alpha causes inflammation. So it is the responsible cytokine for causing the inflammation and the problem in rheumatoid arthritis and in Crohn's disease. If TNF alpha is stopped by some ways, then the downstream inflammation doesn't happen, and therefore the rheumatoid arthritis as well as Crohn's disease can be brought under control. Now, how do we stop TNF alpha? That can be done by monoclonal antibodies. Monoclonal antibody such as infliximab targets the TNF alpha. Fully human monoclonal antibody against TNF alpha is adalimumab that also targets TNF alpha. So both infliximab as well as adalimumab will target TNF alpha, thereby being the first line treatment for autoimmune reaction diseases like rheumatoid arthritis and inflammatory bowel disease. What does the etanercept do? Etanercept has a unique mechanism. It is by itself a recombinant TNF alpha receptor that will mop up or neutralizes the TNF alpha in the bloodstream. It is not a monoclonal antibody, but it has a different mechanism but the same effect. Rituximab targets the CD20 on the B cells. So the B cells have this receptor CD20. Rituximab is a monoclonal antibody. So it will have the FC region as well as the FAB region. The FAB region attaches with the CD20 receptor on the B cells. The FAB attaches region in general, it will attach with the antigen. Here the CD20 of the B cell is the antigen and the FAB region of the rituximab is attached with this CD20. The FC part, right, of rituximab, that is free. That is bound by the complement. C1q complement is activated and the complement gets activated, thereby resulting in the B cell lysis and destruction. So when is this problematic? The B cell is problematic when there is uncontrolled proliferation of B cells, as that which happens in non-Hodgkin's lymphoma, chronic lymphocytic leukemia, as well as in autoimmune conditions. So rituximab is the treatment in these places because it destroys the B cells. But when due to destruction of the B cells, the B cell depletes in number. Now the immunity is also decreased along with the depleted B cells. Progressive multifocal leukoencephalopathy. What is that? That is a potentially fatal CNS demyelinating disease which is caused by JC virus. JC polyoma virus. The JC polyoma virus will not affect people who are immunocompetent. So it will stay latent in the body. But at those where the immunodeficiency, like those who have had rituximab and the B cell count has been decreased and therefore the immunity has come down, there will be reactivation of the JC virus resulting in juvenile progressive multifocal leukoencephalopathy. This is another slide which is explaining why rituximab causes PML. Because the rituximab eliminates the B cells critical for humoral immunity and viral surveillance, that immunosuppression will allow the dormant JC virus to reactivate in the central nervous system. This virus will target the oligodendrocytes, thereby causing progressive demyelination, because oligodendrocytes is the one which can cause myelination of the neural tissues, resulting in neurological deterioration. Let's see more about trastuzumab. Trastuzumab targets HER2. The HER2 new receptor is that receptor which is present in breast cancer. So when trastuzumab targets this receptor, then the breast cancer cells, the cancer cells which express the HER2 new, are also killed, thereby protecting or treating the breast cancer. And sometimes the HER2 new is also expressed. The HER2 new receptor is also expressed in gastric adenocarcinoma, and the HER2 new antagonist trastuzumab is helpful in gastric adenocarcinoma too. What is the side effect? The side effect is that it can cause cardiotoxicity. Why? Because the HER2 receptor, apart from being present in the breast and the gastric adenocarcinoma cells, is also present on the cardiomyocytes. Therefore, it will also affect the cardiac myocytes, resulting in decreased left ventricular ejection fraction and congestive heart failure. You can remember it simply like it is cardiotoxic. What about apiximab? What does it do? Apiximab is antiplatelet therapy. Why do we want to give antiplatelet? Platelets are important, isn't it? This will target the glycoprotein GP2B3A receptors. Why do we need a GP2B3A receptors? For the platelets to first adhere with the endothelium, it is GP1B9. For the platelets to adhere with each other, it is GP2B3A. Now, in certain places where we do percutaneous coronary intervention, like there is already a thrombosis and we are doing an intervention to clear the thrombosis in the heart. Now, when this thrombosis or percutaneous coronary intervention is done with the foreign body, after that and even during that, we don't want any platelet aggregation to happen around the foreign body. So we treat it with the patient with apiximab. It is used as an adjunct therapy during percutaneous coronary intervention. I would love you not to confuse apiximab with adalimumab, which is an TNF alpha inhibitor. What do we know about omalizumab? This is an anti-IgE therapy. Where does IgE becomes a problem? The IgE will cause mast cell and basophil degranulation. So we give them omalizumab such that it attaches itself with the IgE and prevents the degranulation of IgE. In certain asthmatic patients, there is an elevated IgE levels which are uncontrolled by standard therapy. In such case, omalizumab can be tried. Let's see about denosumab. Denosumab is the rank ligand inhibitor. The rank receptor and the rank ligand, if it binds together, it will cause osteoclast activation and bone resorption. The osteoprotogrin is a protective element which will prevent the rank ligand to bind with the rank receptor. But when at times when osteoprotogrin is not present normally, then we give denosumab such that the rank receptor is targeted by the denosumab, therefore preventing osteoclast activation and bone resorption. This is helpful in advanced osteoporosis. What is palivizumab? Of course, it's difficult to pronounce. Zumab. So it is a RSV. It is used in respiratory syncytial virus prophylaxis. This neutralizes a respiratory syncytial virus by binding to the fusion protein, which thereby preventing the viral entry into the respiratory epithelial cells. Its prophylaxis is only in high risk infants. So to whom we have to save the patient by giving, and it is possible only with the pembrolizumab this is used. For respiratory sensitive bronchiolitis treatment questions, what is the treatment? So just because we have known about palivizumab, that should not be the first line treatment. Treatment is always a supportive care, and palivizumab is only in high risk infants. Let's see about the interesting natalizumab, which is an alpha-4 integrin. Where is it useful? This is useful in multiple sclerosis. Before we go into natalizumab, what happens in multiple sclerosis? In multiple sclerosis, there is destruction of the oligodendrocytes by our own T cells. Oligodendrocytes will produce myelination of the neurons. When there is destruction of the oligodendrocytes by our T cells, then it causes multiple sclerosis. Natalizumab prevents the T cells from leaving the blood vessel. Only if it leaves the blood vessels and enters the cerebral tissue, then it will result in damaging the oligodendrocytes, right? If we produce a drug which prevents the T cells migration through the blood vessels, then the T cell damage wouldn't happen. That drug is natalizumab. Alpha 4 integrin is the one which is present on the T cells, which is helpful for adhesion. So when that doesn't happen, when that is blocked, T cell doesn't adhere. Therefore, it is useful in multiple sclerosis, especially the aggressive forms which are resistant to first line therapy. And again, just like how we saw for rituximab, here the immune surveillance is decreased because we are not allowing the T cells to enter out of the blood vessels. Therefore, resulting in an increased PML risk. At this point, I would like to give you some additional information. In leukocyte adhesion deficiency, there is deficiency of CD18 LFA1 integrin deficiency. This is beta 1, that is LFA1 integrin deficiency. The CD18 LFA1 is present on the neutrophils. So they will adhere with the ICAM, PCAM, which is present on the endothelial cells. So when that is absent, CD18 LFA1 present on the neutrophils is absent, then the neutrophils cannot adhere to the endothelium. Therefore, the neutrophils cannot enter the site of injury. That is the problem in leukocyte adhesion deficiency, LAD. Whereas in the natalizumab blocks against alpha 4 beta 1 integrin. What is the tocilizumab? Tocilizumab is interleukin 6 receptor antagonism. The interleukin 6 is responsible for inflammatory cascade in autoimmune conditions. So tocilizumab will antagonize interleukin 6 receptor, thereby resulting in as a treatment for severe rheumatoid arthritis, juvenile idiopathic arthritis, as well as in giant cell arthritis. What about interleukin 2 receptor antagonists? Before we go further, I would like to tell you about interleukin 2. I love this interleukin. This interleukin 2 is produced by the T cells and it acts on the T cells. It is autocrine and paracrine, and it will cause T cell activation. If this interleukin 2 receptor is blocked, then T cell activation will not happen. So at when do we not need a T cell to be activated? In transplant patients, we don't want the T cell to be extremely active and cause transplant rejection. Therefore, basiliximab, which is a chimeric monoclonal antibody, will block the CD15, which is an interleukin 2 receptor alpha chain on activated T cells. This is a standard induction therapy for organ transplant rejection prevention. Daclizumab is discontinued now, but it was previously used interleukin 2 receptor antagonist for multiple sclerosis. But because of encephalitis risk and severe liver injury, it is discontinued now. Let's finish the slide with eculizumab. This is a complement inhibition. In those cases where complement activation is a problem, we can treat them with eculizumab. So when the complement C5 is blocked with eculizumab, this is the treatment for paroxysmal nocturnal hemoglobinuria. I have a separate video on complements as well as paroxysmal nocturnal hemoglobinuria. You can have a look at it. It is a very interactive, and I have provided good animations over there or pictures over there. Okay, so with this we have come to the end of our monoclonal antibodies. I hope I have made it clear to you, and I have a good news. I am starting my veterinary classes. If you are interested in my teaching and if you like the way I teach, you are more than welcome to get mentored by me. Have a good day. All the best for you, whatever exams you are appearing.